Good evening and warm welcome to everyone in our popular Wednesday Wisdom program conceptualized by MahaIP and MahaIP Women Committee. As we all know, Wednesday Wisdom is a program designed with a unique concept of discussing specific topic in one session, and each time 5 new speakers are given opportunity to talk in this webinar. Friends, monsoon preparedness is essential to be known by every pediatrician as rain and humidity carries a wide range of monsoon-related illnesses from the benign viral infections to the fulminant systemic diseases. That means it has a wide range of spectrum of infectious diseases. The topic of today's discussion is based on fever with rash, which are the most challenging and ever-changing cases we all know. Detailed history taking and thorough physical examination, putting together with characteristics of rash along with a high index of suspicion in the cases of fever with rash in our daily day-to-day office practice helps us to reach the probable diagnosis. I, Dr. Manjusha Sherkar, Chairperson MahaIP Women Committee, extend my heartfelt welcome to our MahaIP President Sir, the visionary Dr. Ram Gopal Chejera sir, our evergreen and ever enthusiastic Honorary Secretary General, Central IIP Action Plan Joint Coordinator Dr. Amol Pawar sir, today's expert judges Dr. Sanjay Mankar sir and Dr. Amol Jaibhai sir, all the 5 young dynamic speakers from all 5 zones of Maharashtra, my Women Committee zonal members, co-chairperson Dr. Grivita Raikar, Women Committee Convener Dr. Amruta Baviskar, my co-moderator Dr. Lakshmi Kadu, MMC Observer Dr. Prashant Bhadane sir, Scientific Convener Dr. Bhavesh Mithia sir, and all the esteemed attendees, all the dignitaries, presidents, secretaries of various branches, OBs, EBs of Maha IIP and Central IIP. I extend my sincere gratitude towards everyone for making this program successful each time. Now I request our beloved President, Dr. Ram Gopal sir, to give his opening remark. Over to Dr. Ram sir.
Yeah. Thank you, Manjusha madam. Good evening, everyone, and welcome to the MahaIP platform and another episode of Wednesday Wisdom. Monsoon has already started, so this time we thought we will prepare you for the monsoon. So the title itself says the monsoon preparedness. Now, as you know, the topic is the most common thing is the fever. Now, fever with rash, whether it is a viral, bacterial, or non-infective, we are going to discuss fever with jaundice and then influenza-like illness and severe acute respiratory infections. So, for that, I welcome today's experts, Dr. Sanjay Mankar from Pune, Bharati Vidyapeeth, and Dr. Amol Jaibhai. He is from my own hometown, Thane. So, welcome, sir. Then today's presenter, as Manjusha madam said, we are having 5 presenters from 5 zones. Dr. Arpita Shah from Mumbai, Dr. Pramila Pansare from Pune, Dr. Rahul Kopikar from Nashik, Dr. Jagruti from Sambhaji Nagar, and Dr. Vivek from Nagpur. Welcome all the presenters and all the best. Friends, I welcome our moderator, Dr. Manjusha Sherkar and Dr. Lakshmi Bond from Amravati. Now, this Wednesday Wisdom specifically, this program requires quite a lot of preparations and coordination. So, I appreciate the efforts taken by our Women's Chairperson, Dr. Manjusha Sherkar, Co-Chairperson, Dr. Gravita Raikar, and Convener, Dr. Amruta Bhaviskar. And I congratulate them. They are conducting this Wednesday Wisdom very successfully. Every time we see more than 300 attendance. So welcome all, and over to you, Manjusha madam.
Thank you so much for your constant support and encouragement, Dr. Ram sir. Thank you so much. Now I request our Honorary Secretary General, Dr. Amol Pawar sir, to give his opening speech and encouraging words.
Thank you, Manjusha madam. First of all, I welcome both the experts, my teacher, Dr. Sanjay Mankar sir, and Dr. Amol Jaibhai sir from Mumbai. This time all the speakers are from metro cities: Mumbai, Nagpur, Pune, Aurangabad, and one from Mumbai, Pune, Nashik. Nashik I missed. So welcome all the 5 speakers from all the 5 metro cities of Maharashtra. And this program, previously for first 2 years it was called as Tuesday Techs, and now we have shifted to Wednesday. So it is Wednesday Wisdom. The idea came from Dr. Renu Boralkar ma'am, Dr. Hemant Ganguly sir, and myself 3 years back. And this almost 2.5 years, we have covered almost 32 sessions of this program. Always 5 young speakers are trained to give speeches, and later on some of them might go in various regional or zonal or state level or national conferences also. So guiding them, the experts are doing wonderful job. The women committee, all the zonal members and chairperson, Manju ma'am, then Dr. Grivita ma'am, co-chairperson, and Amruta ma'am, they all are doing wonderfully. So again, I welcome all the delegates and PG students. And now we'll have 1.5 hour session of this monsoon preparedness and fever with rash, as already Manju ma'am and Ram sir has already depicted all the topics and these things. So I wish all the best to all the speakers and wish all the delegates happy learning. Over to you, Manju ma'am.
Okay, thank you. Thank you so much. You are always being a rock support to us so that we can conduct successful all programs. Thank you so much, sir. Dear friends, MMC has granted 1 MMC point. So I request all delegates to write your name, MMC registration number, central IIP number in the chat box to avail this 1 MMC point. Now let us get introduced to our esteemed experts. So for the further proceedings, I hand over mic to Dr. Lakshmi Kadu. Over to Dr. Lakshmi.
Thank you, Manjusha ma'am. First of all, I owe my gratitude to Manjusha ma'am herself as a chairperson of MahaIP Women's Committee. Now, moving to the main program, it is my privilege to introduce our academic and our experts, stalwarts, whose name doesn't need any introduction at all. Our first expert is Dr. Sanjay Mankar sir. He is professor in pediatric and infectious diseases at Bharatiya Vidyapit Medical College, Pune. He is practicing pediatrician and infectious disease consultant at Pune. He is past president, IIP Pune. Our next expert is Dr. Amol Jaibhai sir. Sir is MBBS, DCH, DNB, postdoctoral fellow in pediatric infectious diseases by CMC Vellore. His diploma in tropical medicine from London. His consultant pediatric infectious disease and transplant infectious disease. He is working at SRCC Children Hospital, Mahalakshmi, Mumbai, Jupiter Hospital, Thane, and CTC, PHO and BMT Center, Borivali. He is the Young Infectious Disease Fellow at ASPID 2018 and has won the Travel Award at ASPID 2018 also. He has 7 publications by his name in Index Journal and 3 book chapters with 2 IIP guidelines. His area of interest is transplant in infectious disease, tropical infections, critical care infectious disease, and antimicrobial stewardship. So we are blessed to have them over here as an expert. Now, straightly moving to the main lead of the program, that is to our speaker. And our first speaker is Dr. Arpita Shah, Vakil ma'am. Madam is there. Madam,
Yes.
kindly share
Sure.
your screen. Madam is DNB DCH and she is consultant at Omega Polyclinic, Mumbai. And she is ED member also of IIP Mumbai. So over to you, ma'am.
Can you see my screen?
No, ma'am. Not
No?
yet.
Not it.
Not yet.
Okay, 1 second. I've already shared screen. Have you enabled my screening option? It was
No, ma'am.
No, ma'am.
Option is with you only.
sorry. Yeah, I have done that. Shared the screen, but just give me a second.
Just stop sharing your screen. Yes.
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 Better?
Yes. Yes. Yes.
Yes, ma'am.
You
It
can
is
stop.
visible.
Thank you.
You can make
Sure.
a full screen.
Slideshow mode
Yeah.
was open.
Yeah, slide.
All right. Yeah, let's begin. Yeah, so monsoon has already knocked Mumbai city today in full swing. So it's not just the rains and drizzles which is welcoming. It is a lot of infection and contagious disease also we see with the season going on. Out of this, the most common presentation is fever with rash, which is actually very worrisome amongst the parents as well as physicians because they rub it off on us. Most of them are the viral in etiology and just requires a little bit of reassurance and symptomatic therapy. But as a clinician, we should always be aware of the situations where the complications can occur, which gives rise to significant morbidity in the patients. So the various lesions which we see in the exanthem viral are macules, papules, macular.
Arpita, unmute
Madam-
yourself. Unmute
Madam,
yourself.
kindly unmute yourself. Okay.
Should I?
Start from macule, papule.
Again unmute yourself. Again unmute yourself, madam.
I think somebody is muting everyone. Is it okay now?
Yes, yes.
Yeah. So the various lesions which we see with the fever and viral rash are macules, papules, maculopapular, purpuric, vesicles, bullae, and pustules. This is very important because different morphological lesions will be different etiological agents. So it will guide us for the treatment for the same. So let's start with the most deadly which we see is the dengue fever. Yeah. It has got hanged. Is anybody?
No, madam, no one is moving.
No, that's true.
The-
But
yeah, yes. You have the controls also.
one
Yeah.
second. Yeah,
It's
but
gone. Let it be
Yeah.
on this mode only if you want.
yeah, maybe, yeah.
Yeah.
So let us start with the deadly dengue fever first. Generally, with the fever in the dengue infection, the fever comes on the day 1, but the patient may experience severe backache a prior day to the fever. So that's why it is also named as back break fever. After the fever on the first day, what you get is transient macular generalized rash, which will be easily blanchable with pressure between first 24 to 48 hours. So day 1 or 2, if the patient comes to you and if you press it on the back, you can see the entire handprint is being seen in the picture today. After that, there is a high-grade fever with retroorbital pain, myalgia, headache that remains generally for 3 to 5 days, followed by defervescence. When the defervescence period starts, the Adana rash appears, which is generalized mobiliform maculopapular with occasional edema, but the palms and soles both are spared, which is very characteristic. This is the stage when the third place loss and the coagulopathy and the other complications from like thrombocytopenia start, so one has to be very careful. After 3 to 4 days of such phase, the convalescent phase of the dengue starts, which can be seen as is seen in this picture. So there you can see a little bit of what we call as white islands in the sea of red. So once the patients start getting such rash, we are getting a little bit sigh of relief because that's the time when within 24 to 48 hours, the leukocytes and platelet reversals may start. In case of the dengue hemorrhagic fever, the rash can be maculopapular with scattered petechiae. That has to be kept in mind. And this rash generally heals with a desquamation. The treatment is usual with the fluid therapy according to the third space loss, how the clinical picture present in the kids. The another fever which we see is the chickenpox. Now with the advent of vaccination, we don't see much of a classical chickenpox when there was a centripetal distribution with a lot of vesicular lesions which were like fluid filled with clouding and umbilication. We see more of a breakthrough varicella. So in this generally occurs anytime 6 weeks after vaccination, and rash not being typical vesicular can be just a maculopapular with occasional vesicles. The patient will be afebrile, but we have to keep one thing in mind that even the breakthrough chickenpox, the patient is contagious. The clinical course may remain for 5 to 7 days. It may be lesser than actual chickenpox, but still the child is contagious. So we have to take all the precautions what we take generally for the chickenpox. The treatment in severe chickenpox, we generally don't give any treatment. It's a symptomatic. But in case if there is a pulmonary involvement, we are suspecting some severe disease, or there are a lot of cutaneous lesions are there, you can start acyclovir within first 72 hours of the illness. In the case of neonates, you get if the mother has got chickenpox 5 days prior and 2 days after the delivery, it's always mandatory to give VZ immunoglobulins to all the neonates. And if they get it after post-exposure, means after 2 days after the delivery, mother develops chickenpox, IV acyclovir is the recommended for the neonate. Measles, though we feel it's like we are getting wide coverage in Mission Indradhanush, but still it's not very uncommon to see. The child can present with the high-grade fever on day 1 with coryza and exanthem. We might be able to see Koplik spots, which is 1 to 4 days prior to the rash. If we can pick up this, we can anticipate measles easily. After 3 days of the high-grade fever and coryza, you start getting the confluent rash on day 5, which generally begins on the forehead, behind the ears, upper neck, and then it is generally maculopapular, which is a confluent patch which goes downwards. It also heals in the same way with a little bit desquamation. Sometimes the rash can be hemorrhagic, which is called as a black measles. You need to notify the disease and please give vitamin A to all the cases which are the measles positive. Now let's go to the lesser infective or lesser dreadful measles, which is German measles known as rubella. It is also called as 3 days measles, in which here the rash generally comes first, then the fever comes. Rash is very small, irregular pink macules which coalesces with together each other. And this is also called as 3 days measles because rash generally disappears within 3 days. It is also associated with the fever around 101, but the symptoms remains for 3 to 5 days. It is also contagious, but the spread is centrifugal. In some of the cases, you can see Foch-Hammer spots on the palate and a little bit petechial hemorrhage. So please examine the throat. It will confirm the diagnosis of rubella. Another thing which comes with the throat manifestation is roseola. 6 months to 2 years is the time almost all the infants gets infected by the same. This is called a sixth disease because the fever starts for the first 3 days. It is high-grade fever with coryza and upper respiratory tract symptoms. Rash starts developing on day 4, which is faint pink, morbilliform rash, which is mainly present on the face and trunk. Sometimes it can be blanching. They have clear halos in the center, which is very characteristic. And generally by 6th day, all the symptoms start disappearing. So that's why it is also known as the 6th day disease. In the Asian population, you see in the uvulopalatal junction some spots which is called as Nagayama spots. The importance for this infection is because 20 to 30% of the patients with the roseola infection can develop simple febrile seizures. So please be very careful in managing fever in such patients. They might get recurrent seizure during the course of the diseases. So these are the general 3 things. Measles, the throat will look like this. This is a rubella and this is the roseola infection. Now with the monsoon, what we see is a lot of antiviral diseases. The problem with antiviral diseases, it can affect a wide variety of organs and almost all the systems. What we see in clinical practice mainly is hand-foot-mouth disease, in which the fever comes on day 1. It is generally not more than 101, 102. Rash, which is followed by fever, which is vesicular, as the name suggests, hands, foot, mouth, and it is already present on buttocks also. Rash generally disappears by 7 to 10 days of age. Only symptomatic treatment is required. We are seeing a lot of desquamation of the skin of the palms and soles after enteroviral infection. So if the child comes to you with this complaint, you have to track back the history and see if the 2-3 weeks back they've got some viral illnesses things. And in HFMD, the new symptoms which is seen is the separation of nails from the nail bed, which can occur after HFMD, which is called as onychomatosis, which is being seen quite frequently since last 1 or 2 years. Another fever with rash, the rash in Epstein-Barr virus or infectious mononucleus is not very evident during the illness period. Like only 10 to 20% of the cases with fever, malaise, and generalized lymphadenopathy, which is classical of EBV, will come with rash. But in these cases, there is a pharyngeal exudate. So we may mistaken is at a pharyngitis or tonsillitis. And if we prescribe the kids ampicillin or amoxicillin, that time the child develops the rash, which is maculopapular. So it is an ampicillin rash, which we see more in EBV. Almost 60 to 70% patients will come with this rash. So it is like a diagnostic thing. If you are giving the child, so this is not allergy to ampicillin. This is because the child is infected by EBV. And if you are giving ampicillin, this will give you the rash. So you can diagnose EBV by one of this method too. So parvovirus, or which is causing erythema infectiosum or fifth disease, which is generally affecting 6 months to up to 10 years of age, the kids, which comes with a fever on day 1, but it has got 3-stage rash. It starts with the face, which gives you a slapstick appearances. Then it goes towards the down, which is a macular erythema. Then it starts getting cleared with the center, so it gives a lacy reticulate appearances. These 3 can be interchangeable one after the other also, but this generally heals on its own without any desquamation. Sometimes it gets worse. It gets worsened in the sunlight, and it is a biphasic. So after you get infection once, you might get the similar kind of picture again after 10 to 14 days of the illnesses. The another important variety is PPGSS, which is called as papular purpuric gloves and sock syndrome. It's an acral petechia with painful edema of the palms and soles. It remains for 1 to 3 weeks with such infection. Generally, young adults are infected, and you don't require much to do. It generally heals on its own. The only thing you have to remember is sometimes parvovirus can cause bone marrow suppression, and there is a transient aplastic crisis. So please look for the cell lines properly if the child has got affected by the parvovirus. HSV, herpes gingiva stomatitis, fever and rash almost come simultaneously. There is a painful oral lesions, vesicles in the oral cavity, generally 10 to 15 in numbers, buccal mucosa also. Sometimes cold sores, what we call as herpes labialis, is also present, which gets exaggerated by the fever. We treat this kid by acyclovir, and then they do well. Some of the honorable mentions which we have to see is HIV. We see some pinkish reddish rash, sometimes in Kaposi sarcomas also. The another thing is acrodermatitis, or called as zoonotic crusty syndrome, in which there is a monomorphic skin-colored pink to red papules, occurs primarily on the face, buttocks, and extensor surfaces of the limbs. This generally heals on its own by 4 to 6 weeks of the course, and sometimes you have to give local steroids for the application. This is seen in association with Hep B, Epstein-Barr, cytomegalovirus, and some of the cases after giving influenza vaccines also they have been noticed for this. Zika virus I have just mentioned because last year in November 23, we have got 3 to 4 states in India because of international travel. We have got the Zika virus positive. Out of that, 10 cases were present in Maharashtra. Generally, they come with the fever, conjunctivitis, malaise, headache. They have typical facial rash, maculopapular with slightly vesicular on the face. Sometimes it can go with the cardiac or neurological complications. Otherwise, it's a self-limiting thing. So I have just tried to encapsulate an exhaustive list with particular emphasis given on the what kind of the rash will be present. So before prescribing any antibiotic, please check the throat. See how the rash and fever, what is preceding, what is not preceding, the pattern with the associated factors and features, and have a good friend in pathology or microbiology who can really help you to diagnose and how to form the treatment. Now I'd like to hand over to Dr. Pramila, who will be continuing with the fever with the rash of the bacterial origin. Thanks a lot.
I can explain, my Dr. Harpita Sharma. The notorious viral fever had been all covered. It is very well,
It's
ma'am.
quite an exhaustive list, so
Yeah,
I'll
it
just
was
try to
quite exhaustive.
encapsulate. Yeah.
I would like to hand over the mic to Dr. Sanjay Mankar, sir, for his expert comment. Dr. Sanjay,
Okay.
sir.
Yeah. Am I audible?
Yes.
Yeah.
Yes,
Yes,
sir.
sir.
Yes.
Yeah. Very good evening to all of you. First, at the outset, I would like to thank the organizer, Maha IAP, President Dr. Ram Gopal Chajera sir, and Secretary Dr. Amol Pawar, and entire organizing team for the invite. I must congratulate Dr. Arpita for an excellent and exhaustive presentation on the viral fever. And everybody is aware the viral exanthema. Hello?
Yes,
Okay,
you
sir.
can go on.
Hello?
Go ahead, sir.
Continue, sir.
Go
So
ahead, sir.
viral exanthema is one of the commonest cause of a rash in a pediatric practice, and most of them are self-limiting and doesn't require any treatment. But these rash may initially in serious diseases like bacterial infections, like toxic shock syndrome, or even scarlet fever, or even meningococcemia, rickettsia, the earlier rash may mimic like a viral infection. So it is very important to differentiate these rash from the viral infection and a serious bacterial infection. So the next speaker will definitely cover that. So it's very important to take a detailed history of how the rash appeared, where the rash appeared first, and on which day the rash appeared, what is the morphology of the rash. And very important to take a history of contact with the animals or a history of recent travels and have a look at the systemic examination very well to know. So she has almost covered all the rashes. I would just like to say there is one more thing that is worth mentioning is a rash of the chikungunya. The chikungunya rash would start as a maculopapular erythematous rash along with a very high grade fever, and the rash later on becomes a hyperpigmented rash. When the rash occurs in the neonates, the rash may involve the face and cheek and nose, and it's a classical brownie nose appearance which clinches the diagnosis, so also called as a chick sign or a brownie nose appearance. The rash may be vesicular sometimes with the chikungunya, and it's a diagnostic of the chikungunya. See, most of the viral fever rash and fever will last for a short duration, that may be around 4 or 5 days. But in few viral infection like Epstein-Barr virus infection, CMV virus infection, and adenovirus infection, the fever may last for a longer time, and never to forget HIV. The treatment most of the time is symptomatic, nothing much great is required. But when it occurs in an immunocompromised individual, the rash may be different also, the severity may be different also, and the treatment may vary. And here will be the role of IVIG. Otherwise, most of the time, you won't require any treatment. And in very selected cases of the chickenpox or herpes and hepatitis virus infection, means you may require acyclovir. So but otherwise the acyclovir also will. So try to use acyclovir very judiciously, and don't use acyclovir for the simple cases of the enterovirus infection like we don't use for hand, foot, mouth disease or disseminated enterococcal infection. So follow the stewardship of antiviral drugs also. So that's from my side. So that was a good presentation, and I will hand over to the organizers. Thank you very much.
Thank you, Sanjay sir. That's why the expert comment is most important. The crisp of everything had been told by sir. And obviously the history, which matters a lot. Our next speaker is Dr. Pramila Pansare, madam. Madam, kindly share your screen. She is presenting fever with rash, bacterial origin. Madam is MBBS DCH. She is consultant pediatrician and neonatologist at Atharva Child Clinic from Wakad, Pune. Over to you, ma'am.
Yeah, एक second.
Yes.
This is my slides.
No, ma'am, not. Yes.
Yes.
Good evening, everyone. My topic for today's session is fever with rash, bacterial causes. We all know that it is one of the most common symptoms in our routine OPD. And the most common reason behind this symptom is viral infection, which Dr. Arpita has explained very well. And Dr. Mankar sir has already added so many comments on that. And as he rightly said, most of the time, the differential diagnosis for the viral rashes, we need to think the bacterial causes too, because we all know that bacterial causes are more harmful, or we need to treat them more quickly, or they might land up into complications. So I'll start with, we know that there are many reasons behind these bacterial infections. This is my list, which I have narrowed down because of time constraint. And out of these infections, few infections are milder types, but few are of serious type, wherein we might treat the patient on OPD basis, or sometimes we might need ICU care too. Dr. Arpita has already explained what is maculopapular, Petit purpuras, and we all are aware of those terminologies. So I'll directly start with my actual presentation. So my first disease is scarlet fever. We Puneites have seen many scarlet fever cases in last few months. The common age group for this disease is 5 to 15 years of age. It is a group-A streptococcal infection of tonsils and pharynx. It is associated with characteristic toxin-mediated erythematous skin rash. The patient presents with malaise and fever, sore throat. The tongue is scarlet color. The tonsils are beefy red. We can see punctured erythema on the palate. The skin rash is very peculiar here. It is a maculopapular pink colored rash, and the scarlet fever, the name has come from that pink scarlet color rash. This rash starts from chest and spreads to extremities. It is more at folds and pressure points, and this is called as Pastier's sign. It appears usually on second or third day of upper respiratory tract symptoms. Means on day 1, patient might present just with fever, sore throat, cough, cold, basic viral infection. On second, third day, he might present with this peculiar rash, and that time we need to go for further diagnosis. The rash fades after 4 to 5 days, followed by desquamation. So this is how the rash is. The maculopapular pinkish scarlet color rash seen on chest. Initially, the chest, tongue presentation is white strawberry tongue presentation, and then gradually it turns out to red color, strawberry colored, strawberry like crumb. Now the diagnosis. Our DDs come viral, immunological, drug-induced, everything, but clinical picture is very significant here, and that way usually on OPD basis we diagnose the patient on the basis of clinical picture only. To confirm the diagnosis, hemogram is done which can show raised WBC count with neutrophilia. Rapid CAR test for antigen testing is the bedside test, which we can do to confirm the streptococcal antigen. Gram strain to confirm the bacteria. The penicillin, the treatment, usually penicillin is the drug of choice. In cases of penicillin sensitive patient, we go for macrolides. Here, the treatment is 10 days course has to be completed, because we all know that if streptococcal infections are not treated properly at the acute phase, in future, the patient might land up into rheumatic fever. So 10 days course is very important. In our practice, usually that 30 ml bottle gets over in 3 days and patient does not continue the course. So please prescribe the dose accordingly. The next one is staphylococcal scalded skin syndrome. It is a toxin-mediated dermatolytic skin syndrome, usually seen in young infants. The causative agent for this disease is Staphylococcus aureus. The patient usually presents with fever with malaise. The erythema is seen on head, neck, which progresses to rest of the body. The fluid-filled bullae and exfoliation of skin is the peculiarity of this disease, which gives the scalded appearance, and so is the name Staphylococcal scalded skin syndrome. Here we see Nikolsky sign. It is peeling of skin on lateral pressure. Just mild pressure laterally peels off the skin, and that is called a Nikolsky sign. Exfoliation usually starts from the folds, and desquamation occurs later on. This is the picture which is classically showing exfoliation of skin. Now, again, the diagnosis. Clinical picture is self-explanatory. Rapid CAR test for dermatolysin antigen is the diagnostic bedside test. Throat swab culture can give the confirmed diagnosis. Treatment, usually patient responds well to the cloxacillin and cephalexin. In these cases, topical emollients of skin are very important. As we have said, the scalding of skin is there. So if we won't cover that with topical emollient, then another type of bacterial infection, bacterial infections can occur there. And hydration is again very important, because we know that scalding of skin will lead to dehydration. So hydration is very important. Hygiene is very important. The next comes toxic shock syndrome. It is an acute exotoxin mediated illness. It's usually seen in adolescent. The causative agent is again Staphylococcus aureus. As name suggests, it is an abrupt onset disease. Usually the patient comes to OPD with a sick flu. High fever, malaise is there, vomiting can be seen. Pharyngeal and conjunctival congestion is seen. The rash appears very quickly. Within 24 hours, we can see the rash. And it is a diffuse sunburn-like rash. We can see edematous erythema on hands and feet, which is a non-pitting edema. Strawberry tongue is the one of the feature. Recovery takes little more time. It occurs after 7 to 10 days with desquamation. In this case, the desquamation might lead to hair and nail loss after 1 to 2 months. Toxic shock syndrome, we know that it might land up into critical cases also, and the severe cases might present as shock, DIC, ARDS, renal failure, myocardial dysfunction. So I'll show you the rash. On extremities, we can see erythematous, non-pitting edematous rash, and in the folds, it's a sunburn-like rash. Again, for diagnosis, clinical picture, hemogram, high WBC with neutrophil, raise in neutrophil, blood culture and sensitivity to confirm the diagnosis. Penicillin is the drug of choice here, but in case of methicillin resistant Staphylococcus aureus, we might have to switch the antibiotic to vancomycin. Then next comes meningococcemia. It is one of the again one of the most critical illness, and where we need to pick the patient very quickly, otherwise patient might land up into critical complications. It is usually seen in young infants as well as adolescents. The causative agent is Neisseria meningitidis. Patient usually presents with fever, irritability, malaise, and the rash is very peculiar over here. Purpura fulminans. The name itself is explanatory that the purpura are larger in size. We can also see hemorrhagic bullous lesion and necrotic patches. This disease might lead to meningitis and septicemia. So this is the classical rash. Purpura fulminans, we can say blackish color, large purpuric patches on the back as well as on the extremities. The treatment, a diagnosis, clinical picture, but yes, before clinical picture, before the rashes appears, patient might present with the signs of meningitis, and in that case, we need to admit the patient quickly and start the treatment, considering the meningococcemia as one of the differential diagnosis. Gram-Stein, in cases of meningitis, yes, we go for CSF examination, which will be suggestive of bacterial infection. Blood culture is the diagnostic test. We usually start with third generation cephalosporins. Ceftriaxone has good CSF penetration, so it helps very nicely. In areas where we are not sure about Streptococcus pneumoniae, which are resistant to penicillin, there we might start with the vancomycin also. When we get confirmation on the culture, CSF culture or blood culture about beta-lactam sensitive meningococcus, then we might switch to penicillin. So this is again one critical case where we need to be very particular or very quick in the action. Now I'll mention few of the common but less severe cases. This I'm going to talk because these are the patients we literally see daily. I know that sometimes the patient might not get fever, but the presentation will be with peculiar rash and we can't miss the diagnosis over here. So I'll just show the pictures and the peculiar rashes in these cases. Impetigo, folliculitis, it is the infection of hair follicle, and when it goes deeper, this is called as furuncle and needs oral antibiotic. Penicillin is the drug of choice. Impetigo is usually very common, I think most common skin infection in human being or in pediatric at least. The classical presentation is honey-colored crust rashes, and usually they present with just a few of the rashes on the body, and topical antibiotic usually help. In severe cases, if the patient gets fever and all, we might start oral antibiotic. Cellulitis. It is little deeper infection. It is an infection of dermal and subcutaneous tissue infection. The causative agent is usually Streptococcus or Group A Streptococcus or Staph aureus. Here we need a proper oral antibiotic course. And if the patient progresses to the classical presentation goes with all the symptoms of inflammation, redness, we can feel heat over there and tenderness is there. Some patients might land up into pus formation. In that case, we need to go for the drainage also. Erysipelas, it is a dermal as well as lymphatic tissue infection, and usual organism is Streptococcus, and the drug of choice is penicillin. Thank you. Thank you for the patient listening.
Thank you, ma'am. Thank you very much. Very well explained. I would like to call Dr. Sanjay Mankar sir again for his expert comment.
Yes, it was very excellent presentation on the bacterial causes of the fever with rash, and she has covered almost all important causes of fever with rash associated with bacterial infection. It is very important to have a correct basic knowledge about the bacterial infection, how they progress, how the skin lesions occur, because very important to diagnose them early, because specific antibacterial treatment is available for most of the cases. So it is very important to diagnose them early. So it is very easy to diagnose the bacterial infection if you have known or you have seen the rash previously. So when you have seen a sandpaper-like appearance, it has to be a scarlet fever. When you see a sunburn appearance of the skin, it has to be a toxic shock syndrome. When you see a purpura fulminans, which is suggestive of a meningococcemia, and when you see a palpable purpura, which is involving palms and sole, it is more likely to be a rickettsial infection. And also, when you see a erythema gangrenosum-like lesion, which is seen, it is more likely to be a Pseudomonas infection. And when you also see a skin tenderness along with the bullous lesions or a positive Nikolsky sign, it has to be SSSS. So she has covered most of the causes. It is very important to see when you see a toxic shock syndrome or SSSS, it is all toxin mediated disease. And here clindamycin would be a better choice apart from the routine antibiotics. I would also add few more things. One rash which is worth mentioning is the rash of a rickettsial fever. The rash of the rickettsial fever will arise on a day 4 or 5. Initially, the rash may be a macular or a urticarial kind of a rash. And then the rash, hello, can you hear me?
Yes, sir.
Yes,
Yes,
sir.
sir.
Yes. Yes.
So the rash later on will become palpable purpura rash, which involves palms and soles. And almost the rash will involve all parts of the body. So diagnosis of the rickettsial fever will be by gold standard, that is IFA test, and the drug of choice for all practical purposes doxycycline at all the ages. You alternatively chloramphenicol or azithromycin can be used for this. The second worth mentioning, she has already mentioned, it can be a mycoplasma infection. So the mycoplasma infection also has a different kind of rash, variety of rash. Simple maculopapular rash or urticarial rash is also seen with the mycoplasma, but it may also have Steven-Johnson syndrome like picture, or erythema multiforme like picture, or Gianotti-Crosty syndrome like a picture, or even erythema nodosum like picture. So this rash can be seen in 10 to 20% of the mycoplasma infection. And the rash last, which is worth mentioning, which is not seen nowadays, which is common, is a rash of the congenital syphilis. The congenital syphilis also may present to you as a fever, failure to thrive, hepatosplenomegaly, and may have less weight gain along with this. They may present with a condyloma lata-like lesion and a morbilliform rash or a coppery red color rash, which is seen in a congenital syphilis. So these are other one which can be seen with the leprosy, tuberculosis, and a typical mycobacterial infection, which are worth to mention. So this is from my side. It was a very nice presentation. Thank you.
Thank you, sir. Thank you very much. Take home message has been clearly told by sir and as an expert comment. Over
There's
to
one
Dr.
question out here, treatment of contacts in meningococcal infection.
Okay.
So, yeah, so in meningococcal infection, treatment of contacts will be, there are few drugs like rifampicin, ceftriaxone, and ciprofloxacin. These drugs can be given as a prophylaxis for contacts, or those see the patients directly exposed, or the relative presenting with the associated or staying with the patient.
Okay.
Thank you, sir. We may proceed, Dr. Lakshmi.
Yes, ma'am.
Yeah, okay.
So, over to
Uh,
Manjusha, ma'am.
Yes, thank you, Lakshmi. I think I welcome Dr. Nitin Shah, sir, is there. Nibita, I think. Welcome, sir, if he's there. Thank you, Dr. Sanjay Mankar, sir, for your expert value additions and excellent presentation by two speakers. Now let us shift over to our third speaker. I invite Dr. Rahul Koppikar, sir, from Nasik IIP to deliver his talk on fever with rash of very important non-infective origin. Dr. Rahul has passed his MBBS, DCH, DNB, and he's got gold medal in NNF fellowship. Congratulations! And at present, he is working as assistant professor at Vasantrao Pawar Medical College, Nasik. Over to you, Dr. Rahul Koppikar. Please share your screen. Dr. Rahul?
Yes, ma'am.
Yeah.
My slides visible?
Yes, visible. You are audible also.
Good evening, all viewers, organizers, and experts. Thank you for giving me this opportunity. So Dr. Arpita ma'am and Dr. Pramila ma'am have beautifully described how to approach infective causes of fever with rash. 9 times out of 10 in a busy OPD, it would be infective in origin, but lurking around the corner every now and then there'll be a non-infective cause. Hopefully, at the end of this presentation, I'll make the approach a little simpler, especially when we are facing so many busy patients during the monsoon season. I'll start with a case scenario. A 4-year-old boy presents with fever and sore throat for 3 days. The pediatrician examines him and finds enlarged cervical lymph nodes and erythematous tonsils. He makes the diagnosis of streptococcal pharyngotonsillitis and starts amoxicillin. However, 5 days later, this boy is still looking irritable, febrile, has redness of eyes, tongues, lips, and the oral cavity, and has developed a red rash on his upper extremities with some peeling of skin over his fingers. I think all of us know now that the revised diagnosis is Kawasaki disease. So this case simply illustrates the fact that on day 2 or day 3 of any febrile rash, most of us will find that this is infective in origin and probably start some form of antibiotics. However, as time goes on and newer findings emerge, we must be open to the possibility of non-infective causes. So are there any pointers to a non-infective etiology? The first pointer is chronicity. Whenever fever and rash lasts longer than 10 to 14 days, more often than not, you're dealing with a non-infective cause. Whenever you have progressive skin manifestations, that means an evolving rash, you're probably dealing with a non-infective cause. We must be on the lookout for stigmata of collagen vascular diseases like oral ulcers, joint involvements, photosensitivity, etc. Never miss red flag signs like weight loss, organomegaly, lymphadenopathy. These could be a clue to an underlying sinister disorder like malignancy or autoimmune conditions. A detailed drug history is very important because drugs can cause allergic reactions very late after the drugs have been introduced also. Not responding to medications and some unusual features like peeling of skin that we saw in the first case will also point to a non-infective etiology. Is there a classification for them? Broadly speaking, we have 4 main groups for non-infective febrile rashes. The first group is allergic or immune mediated. In this, we have urticaria and some rare drug-related adverse effects like Stevens-Johnson syndrome and DRESS syndrome. The second group is malignancy. In this, most commonly, we have hematological malignancies like leukemia or childhood histiocytosis. The third group is inflammatory causes. In this, we have our childhood vasculitis syndromes like Kawasaki's, HSP, etc. And the fourth group is rheumatological or collagen vascular disorders, in which systemic onset GI is the prototype. So we'll go through one from each of these 4 categories in detail. What is DRESS syndrome? So this is a rare but very severe adverse reaction that starts late. That means around 2 to 8 weeks after the offending drug has been started. It may present with maculopapular or urticarial rash. There will be high fever, organomegaly, lymphadenopathy, but on CBC, you will pick up eosinophilia, which is the hallmark of this condition. Kawasaki disease, I think all of us are very familiar with the typical diagnostic criteria of the fever for 5 days, 4 out of 5. So I'm not going to go into that. One thing I'd like to highlight is you can get Kawasaki disease in infants as well. And here you have early perineal erythema as a clue, which later on desquamates. We may mistake it for a diaper dermatitis, but when you get all the other features, you will diagnose it as Kawasaki disease. Systemic onset GI is the prototype, as I said, for the rheumatological group. Here you have the typical high spiking daily fever for at least 2 weeks. Although we do find occasionally a faint erythematous rash, in Indian patients, it's very difficult to get this rash. So we rely on the other features like arthritis, hepatosplenomegaly, serositis, etc. This is a very tricky group, leukemia. Broadly speaking, a wide range of rashes can occur in leukemia. The most common would be petechiae and purpura because of severe thrombocytopenia. So whenever we are palpating a rash, it's important to blanch the skin when we have red dots. If red dots on the skin are non-blanchable, then they are likely to be petechiae or purpura. The other type of rash that you see occasionally is leukemia cutis. This is more common in AML. Here, the neoplastic leukocytes infiltrate the layers of the skin, and you can get a wide range of rashes. Most commonly, they start with what you see in the bottom right of the group of photos, erythematous violaceous plaques or nodules. And this generally occurs late in the onset of malignancies. So how do you approach such a diverse group of non-infective conditions in a busy OPD? Our history has to be very focused, but the examination has to be very thorough. We have to try and find the characteristic morphology and pattern of the rash and send only relevant investigations. In the history, it's very important to know how the rash started, where it started, and how it has evolved. Look for additional symptoms like pruritus or tenderness. Never miss red flag signs like weight loss, and always take a detailed medication history. On examination, the first step, of course, is to see if this is a well-looking child or a sick-looking child. Always palpate the neck as well as the abdomen. Don't miss organomegaly or lymphadenopathy. Look for some evidence of connective tissue disorders if you can, if there is joint involvement, oral ulcers, photosensitivity, and then look for the morphology of the rash. So if you look at this list, it's a bit of a busy slide. Almost in every category of rash, you will find drug reactions. So drug history should never be missed. Maculopapular rashes can also occur in systemic onset GIA or DRESS syndrome. Petechial rashes can also be seen in vasculitis, leukemia, etc. And urticarial rashes, which you see very often even in infective causes, you can also see in non-infective causes like insect bite allergy, food or drug allergy as well. I'll only mention one or two visceral manifestations. If you're suspecting Kawasaki disease, it's very important to do a 2D echo to not miss your coronary aneurysms. If you're suspecting connective tissue disorders like systemic GIA, we must do a thorough ophthalm evaluation to look for anterior uveitis. There are two clusters here that you must never miss. First cluster is if you have fever with rash, with hepatosplenomegaly and lymphadenopathy, the so-called reticuloendothelial cluster. This almost always means a sinister underlying cause like malignancy or autoimmune condition. The second cluster is a mucocutaneous lymph node cluster. Here you have fever, you will have an exanthem as well as enanthem. That means there will be mucosal involvement and lymph nodes. So this is your typical Kawasaki and MISC group of conditions. What investigations are we supposed to send? By and large, the diagnosis will be clinical, but whenever the condition lasts more than 10 to 14 days, we would have sent some investigations. So here, CBC, CRP, ESR, renal function and liver function tests to rule out multi-system involvement are generally what we send. And the rest of the investigations are tailored to your specific diagnosis. If you're suspecting a rheumatological diagnosis, you will send an ANA or maybe an antibody panel. And if you're suspecting something like Kawasaki, you would do a 2D echo and so on and so forth. So what is the management of these conditions? Supportive treatment, of course, antipyretics for fever control. Hydration is extremely important. Skin care will change depending on the morphology of the condition. And drug reactions, of course, a very good idea sometimes when you're suspecting a drug reaction is to stop the drug and see how the rash changes. If there's a significant improvement in the rash, likely to be a drug reaction. In conditions like Stevens-Johnson syndrome, these are life-threatening conditions which manifest like burns patients. So you have to give them isolation, multidisciplinary care. In conditions like vasculitis and rheumatological conditions, we need immunosuppression. So here we give steroids, IVIG, biologics sometimes. So what are the take-home points while dealing with fever with rash of non-infective etiology? First is to keep an open mind. Fever and rash is not always a viral exanthem. Second is the longer the fever and rash persist, the less likely it is to be infective. Third is we must be humble enough to revise our diagnosis. If the rash can evolve, our point of view can definitely evolve. When you're examining a child, expose the child completely from head to toe, feel and blanch the rash, palpate the neck and the abdomen, check the oral cavity, also check the genitals, and track the growth of the child in every OPD visit. Take a detailed drug history. This is the third time I'm saying it, but it's very important. And never ever miss red flag signs. Thank you.
Very nicely presented, Dr. Rahul. Congratulations. There is a question someone has asked, what is the treatment of DRESS syndrome specifically? You want to take it? Treatment of DRESS syndrome.
DRESS syndrome is generally handled with supportive care alone. Even after you stop the drug, most of the time the rash may settle for some time, but notoriously, even after stopping the drug, you'll have recurrent flares and episodes, but the treatment is by and large supportive. Occasionally, immunosuppressive therapy is tried, but generally only when you have recurrent flares.
Okay, excellent. You have covered very well. Kawasaki DRESS syndrome, leukemias, drug rash, everything. Very well. Now I request Dr. Sanjay Mankar sir again to give his value additions. And afterwards, if Amol Jaibhai sir also if wants to comment, you can comment. Over to Sanjay sir.
Yeah. Excellent presentation, Dr. Rahul. He has covered almost all important causes of non-infectious causes of fever with rash, and he has given an excellent approach, and he has also stressed the very important point about the history making and good clinical examination to solve the problem. Also his stress on the morphology of the rash, and very important about the investigations, and he has also given a very good take-home messages. So it was a very excellent presentation from his side. When you have a prolonged fever in a office practice along with the rash, you always start thinking of a non-infectious etiology. But it is very important to rule out infectious causes first and then think of a non-infectious etiology. It may happen, it has happened in many seasons for the COVID, that MISC is being labeled and the child has turned out to be a culture-proven enteric fever, or even a brucella, or even any other rickettsial fever. So it's very important to rule out first the infectious disease and think of a non-infectious cause. A little bit of experience will be required, and a humble investigation, serial examination investigation is required to know, because these connective tissue disorders may take time to evolve. So watchful diagnosis is very important. And when you see a morbilliform rash which is associated with the either dapsone or sulfonamides, you will never forget that rash. When you see a salmon rash, salmon colored rash, it is more likely to be SOGI. And when you see a butterfly rash or a heliotrope rash is commonly seen as a dermatoma. So a little bit of experience will be also required for the thing. So serial examination and investigation will be more helpful in diagnosing non-infectious causes of the fever with rash. And it was he has covered it very well. Thank you very much. So it was from my side. Thank you.
Yes, thank you. Thank you, sir.
Sir, just in the last talk, there's one question from the audience. Role of ribavirin in black measles, clinical experience of speakers having used it. Any of the two experts may take it.
Yeah. So ribavirin is used, but it's not very commonly used. We haven't used ribavirin for any measles. Again, the treatment of the measles is a supportive treatment, and there's no antiviral which is a proven for measles. Even for the ribavirin is not proven and not approved. I don't know whether it is available for the treatment or not. For very severe and all, we can use IVIG as a drug of choice for treating the measles. Amol sir, you have to add anything? Jaibai sir?
Yeah. So ribavirin is available, but it is not available nebulized form. It is oral tablets are available, but I have used ribavirin, but not in measles, in other diseases where the patient is immunocompromised. Per se, there is no role in immunocompetent patient. There are several studies done in past. They have said you can give ribavirin to a measles patient, but it's not mandatory. Means it's not proven, and it is available in tablet form in India.
Thank you, sir.
Okay. Thank you, sir. Thank you, Dr. Rahul Kopikar, sir, Dr. Sanjay Mankar, sir, Dr. Amol Jaibai, sir, for your updates in the subject. Very well going, great going, all the speakers. Now let us move on to the fourth speaker. I invite Dr. Jagruti Nikam for my own hometown, IIP Aurangabad, Chhatrapati Sambhaji Nagar. Dr. Jagruti is a consultant pediatrician and assistant professor at MGM Institute, Chhatrapati Sambhaji Nagar. And Jagruti will deliver her lecture on fever and jaundice. Over to you, Jagruti. Yes.
Thank you, ma'am. Thank you for nice introduction.
Yes, thank you.
Good evening, everybody. Now move on from rashes to jaundice. We are covering fever with jaundice in monsoon preparedness. So what defines febrile jaundice? It is generalized yellow discoloration of skin and sclera associated with fever, which is high grade. And why is important to recognize fever with jaundice? What is the etiology? So for understanding this, we discuss this case. This is 4-year-old girl presented with prodromal of symptoms, fever, nausea, vomiting, abdomen distension, lasting from 2 to 10 days, associated with high color urine and yellowish discoloration. On general examination, nothing was significant, only icterus was there. On systemic examination, liver was palpable 4 centimeter, which is soft, and no other organomegaly. So in summary, this is a 4-year-old girl with febrile jaundice with hepatomegaly, suggestive of acute hepatitis of infective etiology. So what is the diagnosis? How to go ahead with this case? So for this, we need to understand what gives rise to fever with jaundice in monsoon. We know that there are different non-infective causes also. There are autoimmune hepatitis and blood hemolytic jaundice, but we are more focusing on the fever with jaundice in monsoon. So there are viruses, bacteria and parasite which gives rise to the febrile jaundice. So leptospirosis is basically waterborne disease, and hepatitis A, E and typhoid are coming from the fecal-oral route, while the dengue, malaria and chikungunya are caused by the mosquito. Now, considering all the diseases which are very common in monsoon, how to go ahead with? Should we send all the investigations? For this, we need to understand what is the clinical picture of the patient. So all diseases present with prodromal symptoms, but the clinching diagnosis is the associated symptoms and involvement of the organ. So we need to understand that the viral hepatitis gives rise to from mild to severe disease, but the liver involvement is a predominant feature, while in other illnesses, the prodromal symptoms and along with the other organs are involved, but they the involvement is more in the severe cases. So after the thorough history, clinical examination, we need to understand what investigation need to be sent. So investigation should be sent depending on the severity and the involvement of the organ and the what is the etiology. So our basic investigations like the CBC can say that it is leukopenia, thrombocytopenia or anemia. So in cases of typhoid, malaria and dengue, this is a common picture, while in leptospirosis, leukocytosis is more common. Raised TSR is seen in leptospirosis. The liver involvement, the elevation of transaminases and the bilirubin is more pronounced in cases of viral hepatitis as compared to the other diseases. And UHG abdomen and X-ray imaging is basically advised to look for the involvement of the other organs and associated features, that is a polycirrhosis. To come to the etiological diagnosis, we need to send the, depending upon the history and the examination, the serological diagnosis of the hepatitis A and E, the IgM antibodies against these viruses, while the malarial testing can be done by the peripheral blood smear, and the leptospirosis, the microscopic agglutination test is the gold standard, while typhoid fever, the blood culture is the gold standard, while the dengue fever can be diagnosed by NS1 antigen, IN, IgM, IgG antibodies. So after your diagnosis, we figured out what is the etiology. So depending on the severity of the illness, whether it is sick or the stable child, we can manage on OPD basis or the IPD basis. That this child requires the hydration and the symptom management. If the complications are associated like the polycirrhosis, encephalopathy, dyselectrolemia, that can be managed in the PICU. If the definitive etiology is identified, like the malaria, leptospirosis, and typhoid, the definitive treatment should be started, which gives the good response. So come to the very common illnesses. This is the first illness, dengue illness, which is very common. Almost all cities are involved. So this is come from the Aedes mosquito, caused by the Aedes mosquito, more coming from the urban areas. There are 4 serovirus are observed, out of which dengue 2 and 3 they give rise to more severe disease. The viral hepatitis most commonly occur in the critical phase of dengue fever, when the fever subsides and in the second week of the illness. The hepatic involvement in dengue is ranging from mild hepatitis to severe hepatitis. It is most observed in the dengue hemorrhagic fever, where the fulminant hepatic failure also reported. Okay. Now move on to the other viral illness, viral hepatitis A. So it increases during the monsoon months from June to September. It is hyperendemic in India, and the exposure is mostly occurs in early life. So the spectrum of the clinical spectrum ranges from subclinical to severe diseases. Transmission is mostly fecal-oral route, and unlike to hepatitis B and hepatitis C viruses, it doesn't cause chronic liver disease, but yes, it gives rise to fulminant hepatic failure, and prognosis in this is excellent. Recovery occurs in 99% of the cases. So how to prevent this hepatitis A virus? Mostly is prevented by the good sanitary practices and vaccination. Initial days, 100% of the newborn used to have the maternal antibodies against hepatitis A viruses. But recent literature said that only 50 to 60 newborns are protected by the anti-HIV antibody. So the vaccination is utmost important. There are two types of inactivated kill vaccines are available. The seroconversion after first dose is 90% and after second dose is 100%. So vaccination is of utmost important. So we need to understand that the peak infectivity of HIV decreases after the onset of the jaundice, and it becomes non-infectious after 1 week after the jaundice, as the liver enzymes also decreased in this period. So the viral hepatitis picture is seen in the hepatitis A, typhoid, and the malaria. We need to understand what differentiates these diseases. In typhoid hepatitis, which is rare, but it occurs in severe form. But the onset of jaundice occurs in second week. And in viral hepatitis, it occurs 1 to 7 days after the fever, and fever is continuous. It is associated with jaundice. While in viral hepatitis, fever disappears after the appearance of jaundice, and the transaminase levels are quite high in viral hepatitis, while in the typhoid, they are low to medium. The resolution of hepatitis occurs after the starting of antibiotic treatment, but the resolution of hepatitis takes much longer time in viral hepatitis. So what differentiates the typhoid hepatitis, viral hepatitis? ALT and LDH ratio, if it is less than 9, it typically suggests of typhoid hepatitis. In malaria and jaundice, it gives rise to mild to moderate elevation in liver LFTs. So it mostly associated with the severe form of malaria caused by P. falciparum and P. vivax, and the jaundice is caused by intravascular hemolysis. But this hepatitis, malarial hepatitis, responds very well to artemisinin combination therapy, and there is no further residual damage. Malaria can be prevented by the WHO recommended vaccines. There are 2 vaccines available, RTS-AS01 and R21. So 3 doses are recommended after 5th month onwards, and the booster at the 2nd year. Now let's move on to the leptospirosis. Leptospirosis is a zoonotic disease caused by the infected water, and the person gets infected by the abrasion at the skin or the swallowing of the contaminated water. Large outbreaks are noticed during this monsoon season because of the flooding and flooding. The spectrum of the viral hepatitis ranges from the self-limiting subclinical diseases to icteric forms. So icteric form is the jaundice and renal failure, which is labeled as the Wales disease, while icteric have the polycirrhosis, myocarditis, and the subclinical symptoms like the flu-like symptoms. So how to prevent this leptospirosis? Mainly clean water, avoidance of contact with the contaminated water, and the removal of the infected rodents. So the treatment, depending upon the stability of the patient, oral treatment can be given on the OPD basis. If the child is sick, can be hospitalized and given IV penicillin. So what is the take-home message from this? So the preventive strategy is utmost important, but the identification of the febrile jaundice, its etiology, is important for the prognosis, because the bacterial infection and malaria are treatable causes of the hepatitis. So that can be, if that is initiated at appropriate time, the patient can be completely well after that. The preventive measures like the hygiene measures and the vector control and the vaccination against the hepatitis A, typhoid, and malaria are utmost important. And the last but not the least, the health education, which is important for the Indian scenario, which helps to prevent the febrile jaundice and its complications. Thank you so much. Thank you, MAHAAP, for giving me opportunity. Thank you.
Excellent, excellent, Jagruti. Very nice presentation. Health education and hygiene and vaccination are the take-home messages. Very nice. Thank you so much. Can I request Dr. Amol Jaibhai, sir, to give his expert comment on the same topic, fever with jaundice?
First of all, I have to thank MAHAAP President, Sir, Secretary, and all team MAHAAP for giving me a chance in this webinar. Dr. Jagruti has presented excellently, and she has covered most of the important causes in India, like as a tropical country, what we are going to see during this monsoon, the most commonly like dengue, leptospira, malaria, then other in hepatitis A and E. So she has given a approach like involvement of a organ, and most common history is like you have to take a like history what they have outside eating, or what is the water, is there any insect bite, so that the we can go towards the diagnosis. And second, depending upon the involvement, systemic involvement and the symptoms, you can send specific investigation to diagnose each infection. So all are treatable infections, can be diagnosed as early into the early stage of the diseases, as there are a very rapid diagnostic test available. So I think she has covered excellent, and also has given a good message like hygiene control, vector control, vaccination. So she has covered almost everything.
So there are a few questions from the audience. Role of Vidal in typhoid fever.
Yeah. So Vidal is not that confirmatory test which we can use and can be sent in a second week of a typhoid fever. The confirmatory or gold standard is still blood culture and the bone marrow, but generally nobody does it bone marrow when you don't have a diagnosis. Then at the end, but still blood culture is the way to go, and it is the gold standard.
So
You can do Vidal, but what?
The next question. So the next question is treatment of very high fever in jaundice and the dose of paracetamol.
You can use normal dose like 10 to 15 milligram per kg per dose every 4 to 6 hourly.
You have a Ray's syndrome, no?
Yeah, probably that is what they want to ask.
Yeah.
Mankar sir, your inputs?
Yes. The paracetamol can be given as a SOS, but low dose around 10 milligram per kg per dose, and will not cause any. But even the fever is high, you can control with the sponging and all. So that's how you bring down the fever, not to the very great extent, but you can bring it down to the 100 and keep it no problem at all. So don't overdose the paracetamol. That's the message. That's all, nothing else. You can use it.
Antibiotic of choice in typhoid hepatitis?
Same, ceftriaxone. Currently in India, most of the typhoid are sensitive to ceftriaxone. So use only ceftriaxone, and the best way, as Dr. Amol has already said, you have to do a culture and sensitivity. Vidal is not at all a good test to detect the enteric fever. So it is a culture sensitivity. So the culture sensitivity will give you which antibiotic to use, and it is all the time ceftriaxone sensitive most of the time. So you have to use ceftriaxone as a drug of choice, even if it is a hepatitis.
Sir, and the last question is malaria vaccine available in India?
As of now, no.
We haven't used, and I don't know whether it is available.
So it
It
is
has
produced
launched in
by the Serum Institute of India, and the many of batches had shipped to the Africa. So it is available, no, but not in a general practice.
Yeah. Sir, how many patients of leptospira can present with jaundice approximately? Leptospirosis.
So leptospirosis, there are like two stages, like icteric phase and non-icteric phase. So most of the time, only like 5 to 15% of the patient will present in icteric phase. Those will be severe form of the disease. They can go into renal failure, hepatic failure. But most of the time, they will present with a like non-icteric phase only in initial stage, like a acute phase, and then there is a immunological phase.
Okay. Thank you, sir. Over to Dr. Lakshmi.
Yes, ma'am.
There are two more questions.
There are two more questions.
Shall we take after the last?
No,
It's
please
in
finish.
continuation with the hepatitis only.
Okay, let us finish
Ceftriaxone is known to cause a gallbladder sludge. Then do we still use ceftriaxone in a case of typhoid hepatitis? That is what one question is.
Recently, we had two patients of severe fulminant hepatitis caused by enteric fever, and we have still used ceftriaxone without any problem. If you want, you can also use cefotaxime as a drug of choice. You can also use cefotaxime sometimes. Meropenem is also a very good drug, but try to have an antibiotic stewardship and use ceftriaxone or cefotaxime as a drug of choice for treating.
Yeah, so as sir said, you can see and go by the antibiotic sensitivity test depending upon the what kind of a strain is that, like whether it is a MDR, XDR, or a simple sensitive strain. According to that, you can use like amoxiclav, fluoroquinolones. But like commonly, once you patient present, generally the treatment of choice will be generally with the ceftriaxone, because we have a lot of resistance with amoxicillin and fluoroquinolones. So I will second the opinion of Dr. Mankar, sir.
7 azithromycin at the dose of 20 mg per kg.
Yeah, see, but in enteric fever, there is mainly you can use a single drug therapy. Generally when on the ceftriaxone or cephalosporin, it will take some time for a fever to differ once. Like it will take 4 to 5 days. In a complicated patient, or if the child is not responding, going into this thing, complication at that time, like yeah, azithromycin will help. That is, it will cover more of like a intracellular coverage and this thing. So, but generally, the single therapy is recommended.
Thank you, Dr. Sanjay sir and Amol sir, and
Manisha ma'am,
Jagriti.
Manjusha ma'am.
Yeah, yes sir.
One more question. It is there. Dr. Madhuri asks. Last 2 weeks, they have kids coming with fever, jaundice, encephalitis. One kid has CSF picture of pyogenic meningitis. So, what could be the possibilities?
Yeah.
Sanjay sir.
Can I have the question again?
Sir, in last 2 weeks, they have a kids coming with fever and jaundice with encephalitis, and one kid has a CSF picture of pyogenic meningitis. So, what could be the possibilities they are asking for?
So, encephalitis along with the jaundice, you need to take again a detailed history, whether the child has a fever, rash, whether the child has a hepatomegaly, whether what is the counts like. So it can be dengue encephalitis, chikungunya encephalitis. So need to see whether it is a viral. And if the child has a picture suggests CSF is suggestive of a bacterial meningitis, see whether it is a pneumococcemia. Pneumococcal meningitis also may have a severe hepatitis and severe fulminant septic shock like picture, like a meningococcemia. Pneumococcemia is also known. So you will have to see what is and what has grown on a CSF. So CSF culture is also important, and we'll try to send a molecular test panel on. So multiplex PCR panel on the CSF would be helpful to diagnose such conditions.
Just to add on that, as it is a pyogenic meningitis, so leptospirosis should be kept in consideration, because leptospirosis is more prone to give the encephalitis-like picture also. So CSF examination of the CSF examination is mandatory, and as sir suggests, the molecular diagnosis is utmost important.
There's
Dr.
one more
Vikram
question here.
Dr. Vikram has asked, can we add steroids for enteric hepatitis? Can we add steroids for enteric hepatitis?
So it's controversial.
Controversial. Okay. So thank you, Dr. Jagriti, Dr. Amol sir and Sanjay sir. Let us move on to the last and fifth speaker. Lakshmi, will you introduce Dr. Vivek?
Yes, ma'am, definitely. So our next speaker is Dr. Vivek Sarde. His topic is ILI and SARI. Sir, over to you. Kindly share your screen. Sir is MD Pediatric and MRCP-CH. He is European Diplomat in Pediatric Respiratory Medicine. He's Diplomat in Pediatric Sleep Medicine also. And he has done his IIT PICU Fellowship also. So, sir is practicing pediatric pulmonologist and intensivist. Handing over mic to you, sir.
Good evening, everyone. My today's topic is influenza-like illness and severe acute respiratory infections. So all of us are getting ready to welcome monsoon. So are the respiratory viruses. And you may be hearing multiple diagnoses at this time. That patient is having cough, cold, viral infection, bronchitis, bronchiolitis, upper respiratory tract infection, lower respiratory tract infection, and so on. So to avoid, and it creates a lot of confusion, isn't it? So to avoid this confusion, WHO has given us two terminologies. One is influenza-like illness, and second is severe acute respiratory infection. So let's see this, what these terminologies are. Before going into that, let's consider that you are sitting in your busy OPD and you are dealing with three patients. First is Amar. He's a 4-year-old boy. He's having fever for 5 days, cough since 4 days. He's having decreased feeding since 2 days, and on examination, you find him drowsy and he is tachypneic, respiratory rate of 60. Then second patient is Akbar. He is a 6-year-old. He's high, almost similar complaints, high fever for 4 days, cough since 5 days. He's having poor oral intake, and he's a known case of congenital heart disease. But on examination, you find him active and alert with respiratory rate of around 30 per minute. And third one is Anthony. He's a 3-year-old boy with fever of 2 days, cough since 3 days. He's playful, he's playing with your stethoscope. On examination, he's active and his respiratory rate is 25 per minute. So looking at this patient, how can we come to a management? How can we diagnose? So I'm sure by the end of this lecture, we will be able to have the idea if we give attention to 4 points. So let's discuss. Firstly, what is the definition of influenza-like illness? I have put old definition, which is not being used just for the reference, and the new WHO definition. We are not referring to old definition because it creates a lot of confusion, and sensitivity and specificity for picking up in a viral infection is quite low. So according to new definition, influenza-like illness is an acute respiratory infection with measured fever of 38 degree or more with associated cough, mainly dry cough, and with the onset within last 10 days. That will tell you it's an acute origin. That's it. Very simple. So acute respiratory infection with temperature 38 degree or more with cough and onset within last 10 days, right? Now, if the infection is severe, then the definition of SARI comes. Again, the old definition was creating a lot of confusion. So WHO has come up with the new definition. And what is it? So again, it's an acute respiratory infection with history of fever or measured fever of more than 38 degree with cough, mainly dry cough, with onset within last 10 days and patient who requires hospitalization. So what are the criteria for hospitalizing a child? So the WHO has given warning signs. So what are those? Please remember, please give attention to this slide. So if the patient is having persistent high fever beyond 3 to 4 days, when the patient is having hemoptysis, when there is breathing difficulty, when there is tachypnea, when there is chest pain, altered sensorium, worsening of the associated comorbidities. For example, if the patient is having asthma and when there is asthma exacerbation secondary to viral infection, it becomes indication to hospitalize the child. Also, when there is inability to feed, when there is persistent vomiting, or when there is a seizure in a young child, these are the signs where patient probably needs hospitalization. So these 3 points plus warning sign will give you a definition of the severe acute respiratory infections. Now let's talk about causative organisms. So what are the organisms which causes influenza-like illnesses? So see, there are, of course, influenza will be there. There is RSV is there, adenovirus, parainfluenza, metapneumovirus, rhinovirus, human coronavirus, and Boca virus, and many more. So see, we need not to be troubled by these fancy names, because all these most of the these viral infection will cause almost similar kind of presentation. That's why there is an umbrella term for diagnosis, which is nothing but ILI, or influenza-like illness. So that's why the presentation as well as management will be almost similar. So let's discuss a prototype of ILI, that is nothing but influenza virus. It's an RNA virus. It has 3 types. Type A influenza virus will cause severe infection in humans. B will cause moderate, and C will cause very minor infection. Now, an important point to notice here is there are 2 major surface proteins on the viral surface. These are hemagglutinin, and there are 16 variants of each, and there is neuroaminidase, which has 9 variants. So what happens? There is intermixing and rearrangement of these surface proteins. That's why you get spike every year. So if the rearrangement is for this year is like minor compared to last year, it will be antigenic drift. And if the rearrangement is major, then it can cause antigenic shift. So if the rearrangement is major and if there is antigenic shift, then this virus has a potential to cause a pandemic. Last time we have seen pandemic in 2009, 2010, isn't it? So this is all about influenza virus. Now let's discuss about epidemiology. So the transmission is through droplet infection or by direct contact. It's a zoonotic virus and it can cause infection in animals, birds, as well as in humans. The incubation period is typically between 1 and 7 days, and patient can be infective 1 day before the symptom to 7 days after the symptom. So the patient can transmit disease to other from between 7 to 10 days or even 14 days in case of young children. Now, influenza viruses can be seen in sporadic cases throughout the year. However, there are two peaks which are noted. For most of the India, it is generally in the monsoon region between July and October. And there is one more peak which can be seen in winter, generally in the northern region of India, mainly in the Jammu and Kashmir, and also in some part of Delhi. Now let's talk about clinical features. So there are constitutional symptoms like fever, headache, myalgia, malaise. There can be respiratory symptoms like cough, sore throat, rhinitis, and also some children will have nausea, vomiting, and otitis media. Majority of the children, I might say almost 90% of the children will have these features and they will recover in 1 to 7 days. However, minority of the children will have severe symptoms, which include viral pneumonia, secondary bacterial pneumonia, like pneumonia, sinusitis, or otitis media. There can be myocarditis, there can be encephalopathy. Also, child may have febrile convulsions secondary to very high fever, and also there can be myalgia and myoglobinuria. Even acute renal failure can happen because of severe myoglobinuria. So these are severe symptoms which are seen in the minority of the cases. Now let's come to the diagnosis. How do we diagnose? Firstly, to identify the organism, we are familiar with this test after COVID, aren't we? So firstly, rapid antigen test, RT-PCR can be done, viral cultures can be done, immunofluorescence, and serology. The serology will give you diagnosis, but it will take a lot of time. RT-PCR, rapid antigen, can give you diagnosis in a short time. And what is the sample? Generally, we can take nasal swab or throat swab or nasopharyngeal swab. And if the patient is intubated, then tracheal aspirate can be taken. Now, important point to consider is transportation. So the sample need to be transported in a viral transport media within 24 hours at 4 degrees Celsius. And if it is not possible, then sample need to be stored at minus 70 degree. If it is not possible, then taking another sample is an option. And other investigations, if the patient is having severe disease or is being hospitalized, and other investigations like CBC, CRP, LFT, KFT, blood culture, X-ray, and other investigation may be needed. Now there are certain high-risk conditions in which influenza-like illness can become severe in children. And what are those high-risk conditions? Please pay attention to this slide as well. So children less than 5 years old, so younger children, those children having chronic heart condition, chronic respiratory condition, chronic hematological, neurological, or liver condition, or children having diabetes, they are at high risk. Congenital and acquired immunodeficiency, of course, they can get severe infection. And children on long-term salicylate or steroid therapy are also at high risk. Now, let's come to the important part, that is management. So, think before act. So, before considering management, just give attention to 4 points. And what are those? Firstly, what is the age of the child? Below 5 years, above 5 years. Secondly, what is the severity of the symptom? Whether symptoms are mild, moderate, or severe. Are there any red flags, which we discussed in the previous slide? And is child is having any high risk condition? So if you give attention to these 4 points, the management become very, very easy. So how do we manage these children? We divide children into 3 categories: category A, B, and C. Category A includes mild symptoms, and for that, just home isolation, adequate hydration, bed rest, and paracetamol SOS for the fever control may be required. Category B, the symptoms are a bit severe and child may be having high risk condition. We know what are high risk conditions. So for these children, home isolation may be required, and if you feel that symptoms are very, very severe, then probably you can shift him to category C. Also, the adequate hydration, bed rest, paracetamol should be given. These children should be tested for the by to identify the organisms, and if it is influenza, then oseltamivir can be started. Should be started, in fact. And category C, in which the symptoms are severe, when there are red flag sign, then in such cases, hospital admission should be considered, and accordingly, child may require oseltamivir, IV fluids, oxygen, antibiotic, and SOS PSU transfer. So this is how we decide about management. Now, let's quickly talk about role of antivirals. So what are the indication to give antivirals? Firstly, when a patient is having confirmed or suspected influenza who is hospitalized, that means he is having severe infection, severe complicated or progressive illness, or when there is high risk of complication, then you need to consider antivirals. Now, what are antiviral drugs which are given for ILI or SARI? Firstly, there are two classes mainly. First is M2 inhibitors, in which amantadine or rimantadine can be used, but they are rarely used in children. Two reasons: because it can cause severe CNS toxicity, and secondly, they are only active against influenza A. The second group are NA inhibitors, which has oseltamivir, zanamivir, or peravivir. Oseltamivir is quite widely used in children, and generally they can be used in even neonate as well. So what are the doses? Below 1 year, you can give 3 mg per kg per dose twice a day, and after that, the dosing is according to the weight. So below 15 kg, you can give 30 mg BD, 15 to 23, 45 mg BD, up to 40 kg, 60 mg BD, and above 40, 75 mg BD. So an adult dose. If you have to give oseltamivir for prophylaxis, for the close contact, then the dose is the same. However, it has to be given in the OD doses. Now let's quickly talk about prevention now. There are two types of vaccine which are available to prevent influenza. One is inactivated and second is live attenuated. So inactivated vaccine have efficacy of almost 60 to 65%, and live attenuated have efficacy of 90 to 95%. However, inactivated vaccine are more commonly utilized. Reason: because they can be utilized in children above 6 months, and also there are very few contraindications, like only when the patient is allergic to the vaccine component, then only it cannot be given. If you are using inactivated vaccine for the first time, then you need to give 2 doses 1 month apart, and then after that annual vaccination should be done, and the dose is generally 0.5 ml intramuscularly. The recommendations are for every child between 6 months to 5 years should receive influenza vaccine. Those older children who are at high risk should receive annual influenza vaccine. We know what are the high risk conditions. Also, healthcare worker and lab person should receive the annual influenza vaccine, and pregnant women and elderly should receive that. Now, a short note on live attenuated influenza vaccine. So it is generally intranasal vaccine, 0.25 ml in each nostril, but there are many contraindications. As you can see, it cannot be given below 2 years, cannot be given in high risk individuals, cannot be given in pregnancy. In asthmatic children, you need to be careful. Immunosuppression, of course, you cannot give. And when there is concomitant aspirin or salicylate therapy, it cannot be given. So let's come back to our OPD patients. Finally, this is the final slide. So Amar, you know there are red flag signs, so you will start treatment according to category C. Akbar, there is some comorbid condition and moderate symptoms, so we'll start category B. And Anthony, mild symptom, category A. Thank you very much for your attention, and I'm very thankful to the MAHA-IAP and MAHA-IAP Women's Cell for giving me this opportunity, and I wish you all happy monsoon. Thank you.
Thank you, sir. Thank you for Amar, Akbar, and Anthony. I would like to call Amol Zaibai, sir, for his expert comment.
Yeah, Dr. Vivek has presented a very good way and giving a like a case scenario. Excellent presentation. Almost cover every aspect of the ILI and the difference between the SARI and influenza like illnesses. So most of the time, like last post-COVID, we have seen a lot of cases of RSV and influenza, adenoviruses. So and COVID, like they have same presentations, but sometimes a diagnostic will help to differentiate and their symptoms and prolongation of fever and everything, how it goes. Mostly, this influenza is like a vaccine preventable disease. So it can be given vaccination to every kid. Plus, those are immunocompromised. For them, it is very important because the disease can go anywhere. It can cause severe complication like acute necrotizing encephalitis, which is called as ANEC. So it is very dreadful conditions. So very well and excellent presentations.
So there is one question. Can we extend the course of oseltamivir?
Normally, the oseltamivir course is 5 days as a treatment, but it can be extended only in patients of like immunocompromised patients or a bone marrow transplant patient. In that cases, if the we can extend this thing, but in normal immunocompetent patient, there is no any role or any advantage of extending the course duration of oseltamivir.
One more related is role of 48 to 72 hours of start of symptoms.
So basically, if you start oseltamivir as early as possible within 48 hours, it will have a good output and the disease will not progress. But still, if you don't have available diagnostics in your hand, so you can use it. There is no harm using it after 48 hours also.
And if it is useful in and effective in all ILI caused by all viruses?
No, it is effective mainly in influenza. Because people has used irrationally in COVID and but even in RSV and all that. But the main role is like it is neuroamidase inhibitor, so it is work against influenza.
I think that's it. These are the questions from audience.
Yes.
Any other questions from our panel?
That's okay. Now you are overshooting time also, no?
Yes, ma'am.
Hmm.
So at the end of the session, I must say, better than 1,000 days of diligent study, it is one day with a great teacher. So as our experts and speaker had proved it very well, I take this opportunity as a Dr. Lakshmi Bond Zonal Coordinator from Vidarbha and Amravati to owe my gratitudes and thanks first and foremost to MAHA-IAP and MAHA-IAP Women's Committee for conducting this program efficiently, involving the speakers from all over the Maharashtra, right from the grassroots level, and giving the fair chance to all the newborn speaker and conducting it meticulously and conveying the topic and covering always a large topic has been covered like fever with a rash and very helpful for the general pediatrician for their monsoon preparedness. And it was indeed a feast of knowledge for everyone on this virtual platform. This would not have been possible without our vibrant guiding support of our president, Dr. Ram Gopal Chajeda, sir. Thank you, sir, for your constant support and happy birthday to ma'am. Of course, I'm also thankful to the right hand of sir, that is our dynamic secretary, Dr. Amol Pawar, sir. I'm also thankful to our perfect leader with the qualities of resilience and clear communications, holding everyone's hand and moving ahead. That is our own Manjusha Sharkar madam, chairperson, Women's Committee, MAHA-IAP. Our co-chairperson, Dr. Grivita Raikar madam, for her being on toes always for the committee. Our stalwarts, that is our experts, Dr. Sanjay Mankar sir and Dr. Amol Jaibe sir, for their light of wisdom and enlightening everyone on this platform. Our young and aspiring speakers for their preparedness, that is Dr. Arpita, Dr. Jagruti, Dr. Pranita, Dr. Rahul, and Dr. Vivek sir. I'm thankful to Dr. Amrita Bhaviskar madam also for being a convener, Women's Wing Committee. Dr. Prashant Badane sir also, as he was MMC observer, he's a pediatric cardiologist from Nashik. And last but not the least, our media manager, that is Pallavi madam, for her constant support and her hectic job. Thank you, madam. Thank you, everyone.
We extend thanks to Dr. Bhavesh Mithia sir
Yes,
being the best scientific program drafting for us. And once again, I express my deepest gratitude to the entire team. Start from Ram Gopal sir, Amol sir, to Amols, Sanjay Mankar sir, my all entire EB members, Grivita, Amruta, Lakshmi, and everything. So special thanks to all the delegates who have joined in very large number as usual, and do join with the same enthusiasm in the next Wednesday Wisdom, which is scheduled on 17th July. Till then, take very good care of yourself and your patients, and goodbye, good night. Thank you so much.
Goodbye.
And here
Good
I
night.
Thank you,
yes,
everyone.
yes, thank you.
thank you, thank you.
ma'am.
Bhavesh
Thank you,
sir, any
everyone.
comments?
So again, excellent presentation. Just a parting comment that tomorrow we have one more webinar of Maharashtra IAP, which is a learning from legend, and it is from the one of the very well-renowned pediatric cardiologists, Dr. Srinivas from again Mumbai Thane, and he's going to speak on lessons learned from the Little Heart with the title of Suno Dil Ki Pukar. So again, we welcome you all tomorrow for the session on pediatric cardiology.
Right.
Okay. Yes. Thank you. Thank you,
Thank you, sir.
everyone.
Thank
Good
you,
night.
everyone.
Thank you. Thank you.